Good evening. I'm Dr. James Riley Monroe Gaskell from the 45th Illinois, which is the 17th Corps Field Hospital. And we have a patient here on our table. He does have a name on him. It's Lieutenant James Smith of the 124th Illinois from Aurora, Illinois. Now, many of the men, when they were going into battle, would put a tag like this, pin it to their clothes. And that's because they wanted to be identifiable. In fact, 50% of the graves that you find in national cemeteries during the Civil War and post-Civil War just say unknown. So he has landed on our table here, and he definitely has some kind of a leg wound. So we're going to anesthetize him. There were over 80,000 operations on the Union side during the Civil War. Unfortunately, we do not know Confederate statistics because most of the records burned when Richmond was taken at the end of the war. So the first thing that I'm going to do is go over to my table, and I'm going to check that his lungs have sufficient power to be able to survive the anesthesia. So I'm going to move his vest slightly out of the way and open up his buttons, and I'm going to use my stethoscope. Now, this is a monaural stethoscope for one ear. It was actually invented in 1816 by a Frenchman named Lanark. Now, Lanark never patented it so that anybody could make a stethoscope, a wooden stethoscope, during this time period. We were just starting to have stethoscopes that went in both ears like the ones today, but they weren't widely known, and a wooden stethoscope is far easier to hang on to and less likely to break during the war. So we're going to check all 4 lobes of his lungs. Okay, that one seems pretty good. Let me move down a little. Yeah, good breathing. Check on this side. Yeah, that's pretty good. Yeah, that one's pretty good too. We're going to now check his pulse. So I'm going to measure him here for about 30 seconds and see how many beats we have. Seems to be a pretty strong heart. So I think he can survive the anesthesia at this time. So anesthesia, this is the 3rd war that we're using anesthesia. The first war was the Mexican War, 1846 to 1848. The second major war that we actually had anesthesia was the Crimean War, which was 1854 to 1856. We are now in the 3rd war, so we are very good at using anesthesia. And by the way, somewhere between 95 and 97% of the people who required any kind of major surgery did get anesthesia during the war. No, they did not bite on bullets, they did not bite on sticks, only in Halloween and Hollywood movies. So the first thing we're going to do is we're going to take our ether cone, and you'll notice it has a large area here and a small area here. We're going to drip some ether or chloroform in here and place this over the person's face. It'll turn from a liquid to a vapor, and as a result, they will go to sleep. Now, normally this takes somewhere between 9 and 12 minutes, so we're not going to take quite that long. We're going to grab our can. In this case, because you'll notice a candle is lit, we're approaching dusk, and ether is highly flammable, so we're going to use some chloroform. Doctors usually did this. Grab a cork in their mouth, put a couple of drops in the top, put the cork back, and place this over the person's face about 2 fingers high. And that is because chloroform is acidic and we don't want to burn the person's face. We tell the patient to deep breathe. Nice big breaths. And after a while, we'd start to find out if the patient was actually asleep. And the easiest way to do that was to take our finger and rub it across the eye. If there was no movement of that eye, then the person was totally asleep. If there was any kind of reflex action, we had to give them a little bit more chloroform. Now, he'll be under about 22 minutes. So we should have plenty of time to look at that leg, and if we have to do an amputation based on what we see, we will definitely do that at this time. think he's pretty well asleep. Let me check that eye again. Oh yeah, we have no movement of the eye at this point. Let's check his breathing again. Good breaths. So he is totally under. Now there's 4 different levels of anesthesia during this time period. Level number 1, they can still feel and hear things. Level number 2, they can hear what's going on, but they can't feel anything. Stonewall Jackson, when he was anesthetized after the Battle of Chancellorsville, told his doctor, Dr. McGuire, that he could definitely hear him amputating the arm, but he couldn't feel anything. What we wanted is what we saw right here, and that is level 3. They can't hear or feel anything. And we have to be very careful because out of 80,000 operations, 36 people were over anesthetized, and that's level 4. They're dead, which is what we don't want to have happen to our patients. So we'll kind of keep an eye on him off and on while we're actually doing the surgery itself. Okay, we've moved to the other end of the patient now that the patient is asleep, and we're going to find out what the problem is with this leg. You'll notice this leg has some blood flow problems, so we may have to do an amputation. First thing I'm going to do is I'm going to find my Nielton probe, and I'm going to see if there's actually a bullet in there. And what a Nielton probe has is a piece of porcelain on the end. Nielton was from France. And when you put this into a wound, if it ends up with a mark on the porcelain, it has hit lead, and you know that there's a bullet inside. Now the patient is asleep, so I'm not going to be rough, but I'm not going to be terribly gentle. I don't have to be. You would have up until the War of 1812, and that's when we didn't have any anesthesia. So I'm going to put this in there and twist it a little and see if it seems like there's something in here. Oh yeah, we have a mark on it, so we definitely have some type of bullet. The next step is to take a scalpel and usually to open the wound up a little. So I'm going to push the bandage to one side and I'm going to do a little cutting here. There we go. And I've now opened up that wound. Now the next step is to remove what is ever in there, and I have stuck my finger in because that is the best probe for a doctor. It's connected to a brain. So I have a bullet extractor here. I'm going to see if I can find out what's in there. I know there's a piece of lead. So I'm going to stick it in there, and I'm going to see how I can pull it out of there. And whatever's in there, the muscle has definitely tightened on it. There we go. And we have a 57.7 caliber mini ball. Now this one looks fairly pristine. A mini ball goes roughly 3 football fields. Now if this was a hexagonal mini ball, 6-sided, you could shoot that 8 football fields. In this case, it went probably 3. It was at the end of its trajectory when it hit this leg. And hopefully, we're going to find that the bone itself has not broken. So we'll get rid of this. And we'll use our probe again and see what we can feel in here. I'm not feeling anything sharp. No, definitely there's nothing sharp. If there isn't, the gentleman gets to keep his leg. You hear that, Lieutenant? Oh, I know, you're asleep. Now, we did have 3 different saws that we could use during this time period. The capital amputation saw was basically to take off legs. The metacarpal saw was to take off feet and hands. And of course the one that looks like it probably belongs at Sirloin Stockade or some other steak place today, this one would take off fingers and toes. But since we don't have any of those problems, we'll throw those back in the case. Now, one of the things we sometimes do is we sometimes put a small piece of linen in the wound. And I'm going to grab my scissors here. Sometimes it's lint, which is cotton thread. Sometimes we'll take a piece of a bandage and kind of wad it up and put it towards the wound to absorb anything coming out of that wound itself. We will do one other thing, and that is we have a brand new painkiller at this time. It is morphine sulfate, and it's in a salt or pulverized version. And so what the doctor would do is lick his finger, get a little bit on there, as you can see, and kind of rub it into the wound area to, in a sense, anesthetize or kill the pain of the wound itself. Yes, I did lick my finger. We don't know anything about germs. Germs are not, quote unquote, invented until 1866 when Dr. Lister publishes his first paper. And we really don't have antiseptic surgery in Wisconsin until the 1870s and 1880s. You know you have antiseptic surgery when they get rid of the wooden handles on the instruments. Notice it has a wooden handle. Wood cannot be sterilized. Once we go to all metal instruments, you know we've made the transition. I will now kind of push that bandage over. I'm going to put another bandage over the top of that. There we go. Kind of twist it and push it in. And we are ready to wake up our patient. So we're going to stop and move to the other end of the patient again. Okay, so now at this point we're going to wake up Lieutenant James Smith. Now, the easiest way to wake up a patient is, first off, he's starting to have a little bit of eye movement, so he is starting to become conscious. What we primarily did was we would take our two hands and we would slap the patient and tell the patient, wake up, yell at the patient, and try to get that patient to breathe deeply, get some more air in the lungs, get rid of the chloroform or ether that had gone into their system, and wake them up. Now, normally the first thing a patient like this would do is the patient would take a look down at their leg, because they knew we were going to operate on it, and they wanted to make sure that they got to keep the leg. And in your case, yes, Lieutenant Smith, you did get to keep your leg. The bone was not broken. We call that the Humpty Dumpty effect because we could not put it back together again, just like the child's nursery rhyme. If the bones were shattered, they lost the leg. If the bones were not shattered, the person got to keep their leg. Now, this patient will go to a post-op area and eventually end up probably somewhere between 200 miles and 500 miles from where he's at right now in a general hospital. He will recover in that general hospital, and if he doesn't have too much inflammation in his leg, we didn't know the term infection until after 1866, he'll keep that leg. It might get red, it might get a little warm. Since we're in 1864, if he does start to see black spots on that leg, gangrene, we can cure that now. We have bromine, which was discovered in 1863 in Louisville, Kentucky. And Dr. Goldsmith figured out that if you paint bromine on a wound, it actually kills the gangrene. Bromine is in the same chemical group as chlorine, and of course today we use that in pools to get rid of things and keep the water safe. So, Lieutenant Smith, you were very lucky, didn't break anything. You will go on and probably go back to your regiment, the 124th Illinois, in about a month or 2 months after your leg has recovered. And thank you. That's the end of our demonstration tonight. I will stay on the line so that if anyone has any questions.